Good afternoon and welcome to this MedIQ Facebook Live event entitled Aging Services and COVID-19, Clinical and Legal Perspectives. My name is Mark Hakem and I'm Director of Risk Management and Patient Safety here at MedIQ. I'm here today with Kelly Papa, Vice President of Strategy and Community Life at the Duncaster Life Plan Community in Bloomfield, Connecticut. We also have Rebecca Adelman, founder of the Adelman Law firm out of Memphis, Tennessee. Rebecca specializes in the legal defense of long-term care facilities. Today, we'll be discussing the clinical, operational, and legal impact COVID-19 is having on the day-to-day operations in aging services organizations, and life planning communities. For those of you joining us live, make sure you post and send along your questions. We'll do our best to answer them during our time together. Kelly and Rebecca, thank you so much for joining us today.
Thank you.
Kelly, let's start with you. When we initially met to discuss the program, you were telling me that one of your primary concerns at the start of this pandemic was taking care of the 4 C's. Would you mind going over that again?
Oh, sure. So I'm a nurse by background. And so when I think about a pandemic and I think about preparation for a pandemic and how we can lead our aging services community at this time, the 4 C's come to mind. That's care, compassion, communication, and containment. And so I just for a moment, would it be helpful, Mark, if I kind of unpacked each one of those a little bit?
Yeah, that'd be great. Please do.
So care initially kind of goes over all the needs that we would have for the people that we're serving. And so when I think about the clinical needs, the nursing needs, we want to make sure first and foremost, we were following and building policies, procedures, education around the guidelines that were coming out from CDC and DPH. And that was an ever-changing, evolving, still fluid approach. And really figuring out how are we caring for the needs of those who we suspect may be affected by COVID, who we're testing and awaiting, and those who are diagnosed with COVID. And so it was really a 3-pronged care approach, also in prevention within that. The second C is containment, and extremely important to make sure that we kind of contain ourselves as much as in a bubble as possible. And so we want to prevent the spread, we want to prevent it from coming in, and this is an ongoing daily effort to contain. We work really hard to prevent cross-contamination, so each one of our neighborhoods kind of become that own bubble, if you will. Along with containment was a lot of personal responsibility for our staff, which requires a lot of education to say, you know, are we making sure that we are doing all we can personally do to not bring the virus into our community? And so lots of opportunities to say, you know, I know you might work 2 jobs. Would you consider which one would make the most sense for you in your life right now? And having those very sensitive conversations. So our HR partners have been great in that, and our department, and really trying to make sure we can contain. We make sure that we hold out our packages. We have that single point of entry. We have great conversations. In the beginning with containment, it was, you know, always evolving, right? We've all been through this where at first you're just doing a couple things, and now we have to say, oh, we're going to limit visitors, and let's not have any visitors right now, and only things that are health and safety. And so that took a lot of education on all of our parts. And so this C helped us build those critical thinking skills we each need, be able to apply during a moment of real life, right? Taking the classroom knowledge into the real life. And so we always asked 3 questions. The first one was, if somebody wanted to come in from the outside and was kind of, I don't know, going through that barrier for containment, does it have to happen today? Second question, can someone else do it for you? You know, you want to run to the pharmacy, can one of us do it for you to keep our residents on campus? And the third question was, is this a health or safety need? Does this have to happen right now for this person's overall well-being? So second C, containment, first C, care, third C was communicate. And this was essential. And so how do we build really a fabric of all stakeholders? So that way any information has like a 2-way movement, right? From every stakeholder, our residents, families, community, all of our staff, because the great ideas and questions and concerns that once unpacked became great ideas, all needed to have a very fluid way. And so I could tell you later if anybody's curious about how that kind of unraveled, but communication was huge for the well-being of our residents as well. We needed a daily touch point for every person to make sure that their emotional well-being was being met. Their safety was always, we were on top of it. And a usually very vibrant, relationship-oriented, buzzing community got very quiet very quickly. And That's very hard on everyone. So right from the beginning, we initiated, this was early March, we initiated a buddy program. And our wonderful staff members from many departments, HR and marketing and finance and wellness, said, yeah, I'll be a buddy. And each one of them got a list of residents that then we're able to build these great relationships with over time, to check in on and say, how you doing? Do you need anything? Life like? We help you with your family over Facebook. All these different ways to make sure that we were connecting with everybody, at least daily. And for some, they didn't need us to connect daily, and we moved on. But for others, they really did need this daily connection, and still do. And so the buddies then played a vital role in figuring out who are our kind of, who's in the red zone, who's in the yellow zone, and who's in the green zone. Those residents that we feel like are in the green zone, independent, we're still making sure we're in there for wellness and fitness and all those pieces, connecting with them. But for social isolation needs, we're okay. You know, we're holding our own. Yellow, these are some folks that we want to make sure we are helping from a wellness perspective and clinical perspective, et cetera, reaching out to families. And then reds really become those clinical people. How do we make sure so that communication approach really helped us. But it also then evolved into what was the fourth C. It didn't start with the fourth C. At first, it was just the three: care, contain, and communicate. The fourth C bubbled out of living all of this. And the fourth C is compassion. Because the reality is, this is taking an emotional toll on everybody. Everybody. We all are experiencing something personally and at work. We're all, it's not business as usual, as my CEO, Mike O'Brien, always says. This is different. We have to be nimble. We have to be decisive at times and figure out if we did it right after. But we have to move. And the reality is, this does a lot to our sense of security and social isolation, worry, gracious assumptions for team members, and to make sure that, you know, we each go home at night. And I know for me, I am extremely grateful for this team, but I'm very grateful for my friends and family too. Because when I get home, I'm sad, I'm worried, concerned. I'm on the phone, I'm reading, I'm watching videos. I'm trying to learn all I can to make sure we didn't miss a guideline, that there wasn't a regulatory topic that came up that I absolutely, or my team didn't catch and apply right away, or did we even apply it the right way? And is it sustainable? And that sense of worry every night, I know we're all going through as well. So that ability to have compassion for one another was the essential fourth C that I think tied us together in our culture here at Duncaster.
Great. Thank you, Kelly. Now, you talked about the worry and about missing something. And, you know, some states have Good Samaritan laws. And it's my understanding, Rebecca, that many states now are developing or have what are called immunity laws. Is that correct?
Yeah, that's right. And I do just want to shout out to Kelly, because I've enjoyed preparing for this Facebook Live with you, and appreciate how you have shared not only the impact of the 4 C's on your community, but how this pandemic has impacted you personally. And so today I'd like to kind of share what the pandemic emergency immunity laws are looking like throughout the state. So healthcare providers, long-term care providers along the continuum of care in aging services are fortunate enough to have good guidelines. They are ever-changing. CDC, CMS, and a lot of incredible resources in order to implement and stay on top of these guidelines. But beyond that, what we have been advocating for since the pandemic started to reduce the amount of worry that Kelly and her team have to carry are protections for actions, good judgments, clinical judgment, operational administrative judgment that is being made during the time of emergency. So to reduce the worry and the concerns of lawsuits and legal action. So there have been a lot of legal implications, as you can imagine, from the pandemic, as we are seeing patient surges, as we're seeing sites for healthcare expand and change. We're seeing physicians being asked to practice outside their scope, and other healthcare providers being asked to practice outside their scope. And we're seeing limited resources. There isn't a day that goes by where we're not seeing now in the media, in all sorts of reporting, regulatory and otherwise, how there are limitations in PPE, there are limitations in staffing, that are, have developed around this pandemic, many of which are out of the control of the healthcare providers. So really early on, New York was kind of at the forefront of passing some state emergency immunity laws. We've got executive orders from governors as well as statutory changes in states now. And they vary from state to state. So for those of you who are listening, make sure that you do check with your state to see what's developing there. I'll be happy to answer any questions about what we're seeing across the states. However, the real critical key components of most of these immunity laws relate to actions of negligence versus actions of gross negligence. So the types of protection that we're nearly seeing across the board in those states, which are about half the states right now, that are either through executive orders or through statutory and legislative changes, providing immunity to healthcare providers. It's a very broad definition in some states, not so broad, ill-defined in other states. So we're still, there's going to be a lot of interpretive issues later. But at this juncture, the immunities and the coverage and the protections are for negligence actions, and excluded from immunity, excluded from protections from legal action are gross negligence, bad faith, decisions that are made with intentional conduct, very similar to what we see in other immunity laws that predated the pandemic. So, we are on my end of it, we're grateful for the advocacy that the organizations that we're involved in have been making at a state level, but really having some type of a federal immunity laws are going to be very important. The major organizations that are working with our government to pass those laws, which will probably be tied into a benefits package, we will see, but there is no kind of overreaching federal law right now on providing immunity to healthcare. So we're looking to our states. So we'll see how that evolves. It is ever evolving, but I think what's most important is that there's some peace of mind to the healthcare providers, to the administrators, to the folks that are on Kelly's team and teams around the country like Kelly's team, so that they have some peace of mind about going to work, unhesitatingly brave in their actions day in, day out. So,
right. Okay, yeah. Great. Hey, we got a question from the audience already, and it says, I'd like to know how risk is being managed from two opposing perspectives or two opposing points. One, responsibility for not containing the virus, and two, too much isolation and responsibility for negative health aspects of residents. Mm-hmm. So Kelly, what are you doing to contain the virus? You talked about the cohorts and keeping them in a bubble. What other things are you doing to maintain or contain exposure of the virus amongst your residents?
So my mind kind of goes in two places that I want to make sure I'm answering the question. The first piece is a little bit about our continuum of care. We are a continuum of care retirement community. So we have a skilled nursing, we have assisted living, and we have independent living. So talking about a little bit of each of the things we're doing in each of those very different environments. So in skilled nursing, we want to make sure, and we have this outstanding life enrichment team with Jeff and Katie and Mackie, and they have been every day creating some moments of joy, whether it's singing in the hallway, whether it's a game that others are playing, if it's setting up FaceTime and a window visit or a much needed breath outside. Every day they come in with the intention of bringing moments of joy and preventing social isolation as in an environment where it's very possible. The other piece, and I wanted to move into, is this idea of we care for people who are affected by dementia and Alzheimer's. And so how are we making sure that they have a sense of safety and security in an environment where now everything is different and we're masked, and that's hard for communication. And so I very much value the education and the application of the education that our care partners are able to have for those residents as well, because their moments, their day is all hinging on a sense of emotional well-being. And so that's a daily knowledge of each resident and what we can be doing for them. On our independent living and our more social assisted living side, our buddies have helped tremendously. Our wellness department, Lucy and John and others, have definitely worked to find ways to bring moments of joy. We have some residents who definitely wanted to have a bicycle, what do you call those things? Just an inside stationary bike in their apartment, because that was what was going to bring them joy. That ability to ask that question of, what do you need today? What would be helpful? We've spent a lot of time making videos and putting those out and encourage people to go outside. I think probably the most important on our side for our independent living residents, and I miss them terribly and get feedback all the time from all of them, which is great, is the ability to make sure that they have routines in place, that they're able to ask for the things that they need. We have these sense of spontaneity. We use the in-room cable stations quite a bit, but also their education and their ability to make good decisions about what they do and don't do. I trust. And so if they've recognized that this is something that is a need for them, they want to talk it through with me or others, we always do that. But the other part of the question, I think, may be going this direction of what are the tools we use to make a decision about what we do or don't do? What are the tools and questions we have to ask ourselves as we start to think about opening things up? What does that look like? So we have focused on 4 questions that usually just develop into more questions, but it's our opportunity to be really intentional about vetting all the perspectives that exist within a need. Those 4 questions, again, out of nursing and other medical fields, are first, what is the risk of doing it? Second, what is the risk of not doing it? Third, what is the benefit of doing it? And fourth, what's the benefit of not doing it? And so when you start to tweeze out each one of those questions around a certain service, hairdressing, fitness classes, doctor's exams, podiatry, all those pieces, the answers start to emerge a little bit more clearly in this very murky place where we are. So I hope that answers some of it.
Yeah, I think it does. And the second part of that question, how are you managing the risk from too much isolation? A lot of elective surgeries across the country have been canceled. Some of those are affecting our aged populations where you're at, Kelly, but throughout all of healthcare. Rebecca, I'm going to direct this to you. Are the immunity laws protecting those situations that delay in cancer diagnosis because they didn't get their routine mammogram, delay in, oral problems and because they didn't go to see the dentist, things like that? Is that where this immunity law is going to help out our healthcare providers?
That's a brilliant question, because the answer to that is we just don't know right now, because we're depending on the states to design their own immunity laws. Some states have very broad language about what actions are protected. Could be language, for example, any actions that are related to or a product of the COVID pandemic, which could account for executive orders that have ceased elective surgeries, or staffing shortages. For example, someone comes to the emergency room with a non-COVID emergency, but because there is a staffing shortage in the emergency room that is being directed toward COVID patients and the pandemic patients, there just isn't enough time, there aren't enough resources to address the issues on an incoming patient with non-COVID related condition. So the question is, if that person suffers an injury, has a heart attack, goes untreated, the treatment isn't complete, or the treatment can't be completed because of certain limitations and resources that are being redirected. It's on a state-by-state basis at this juncture. So might be protected, might not be protected. I think that's why having some overarching, very broad legislation, of course, keeping in mind, we have a balance here, by trade. For 30 years, I've been a defense lawyer. I defend the healthcare space, doctors, hospitals, assisted living, all along the continuum of care for all my my professional life. However, there's also the balance of good governance is about including the balance of the rights of patients to receive care. And I think that's where you're hearing Governor Cuomo speak to the issues of making sure that patients in nursing homes are getting the I don't think they can get the best care possible. It's just not possible when you're in an emergent crisis battlefield set of conditions. And so I think we're going to see some variance in what the standard of care is for, across the board for COVID specific and non-COVID specific.
Great. Thanks, Rebecca.
Mhm.
So Kelly, another question. What are the best practices for planning how families can visit now as states start to begin opening up? Have you got anything in place for that at the current time?
We're talking about that right now, and we're so lucky to have our leading age members, and our association, Magmarelli, has really helped us create good dialogue conversations around it, so that way we can vet kind of all the concerns. Coming up to the windows. Can you not open a window? What if someone doesn't have a window? All of those pieces. We are so blessed at Duncaster to have in our skilled nursing private rooms. And so they each have a downstairs window, which has been outstanding. We miss our family visits. We know that they're essential for the residents. And we've relied a lot on FaceTime, Zoom calls, all of those telephone calls, all the photos, letters, all those things that we can do. But we're definitely working very closely with partners in other life plan communities to go again through those 4 questions of what are the risks, what are the benefits on both sides. And so to make sure that we have a very clear path that we feel safe and secure with. We also want to be mindful for some residents, especially those affected by dementia, the ability to maintain a 6-foot distance, even through a window, may have some unintended emotional responses. And so what do we do with that? And how do we be very, as nurses are, how do we be very individualized in making these decisions, in definitely in collaboration with families, and having those great conversations. I had a conversation with a son of one of our residents yesterday, and he said, I'm okay right now. I've visited her a lot. I think it's best that I don't come right now. And we're going to set up a FaceTime call for that. So, but people really taking a sense of self-responsibility in making these decisions, and the partnership with our staff and our teams has been essential.
And Mark, if I may, I think what we're going to also see from the CDC, from CMS, from the states, are continuing guidance and guidelines as the healthcare industry starts to open up at all different levels. I think we're going to start to see that guidance, and Leading Age and other organizations that Kelly and I are both involved in are really leading the way on designing those to the really kind of to the best standards, practical for the psychosocial, physical well-being of our elders. So I think we're going to be seeing some more guidance come. And Kelly, I know this goes without saying, but make sure that everything is well documented, right? That we're documenting the actions we're taking, the conversations we're having, what's working, what's not working, taking those 4 questions and writing down the answers, so that in the event, unfortunate event, that something does happen later on, as we start to open up and there's another resurgence of the virus, let's say, at a community, that we've well documented the steps we've taken, consistent and compliant with regulations and our own internal standards. So just some free Facebook Live advice there.
You want to document that rationale, right?
Right.
So I got another question here. Hold on one second. Here we go. And I believe this is directed to Kelly. How are you communicating change in resident condition to families during this time when they are not seeing their loved ones on a consistent basis?
How are we communicating? Definitely phone calls. And we're all always happy to have, lengthy phone calls, just so all the questions can be asked and answered. And a lot of times this place of concern brings us to deeper understanding. And so if somebody calls up just out of deep concern or worry or frustration, the ability to walk through all of that and unpack all of that is essential for these families. Definitely the pre-existing relationships our staff have with our families and our residents has brought about trust in these moments. And that has been nothing but extremely helpful to really partner with them. So, and I would also share, our medical practice on site here, Hartford Healthcare, they have been using Zoom, and so then that way you can talk with multiple family members and the resident and the physician, and that has helped a lot as well.
And that sounds like it's fallen into your 4 C's, your one of communication, to kind of maintain those relationships and that information to the loved ones of the resident.
Absolutely.
Okay, got another question, and I believe this is directed to Rebecca. I spoke with a peer who works at an ECF, and they are closed to visitors until September 9th. She voiced concerns that families may bring suit in order to visit their family members. Is this a real possibility, and how should a risk professional be prepared?
So that's a very good question. In fact, I have a colleague of mine who is in the process of managing an injunction action. A family member wanted to visit a loved one in an ECF, and because of internal protocols, because of what the status of the population was at that time and employees, they were prevented from doing that. So they filed a particular legal action to get access to the facility, a temporary access to, an injunctive action to allow them to see their loved one. That has now gone from kind of a local court to a state court. All of these proceedings are happening by Zoom,
Wow.
no one can go into the courthouses. So these processes are very long and very drawn out. And I think we are going to be seeing some legal action. However, I think that, with the guidance again from CDC, from CMS, and then our state regulators, I think we can count on that to help with protections for operators if there is a threat of a lawsuit, or someone, someone wants to, doesn't want to comply with what's going to be in the best interest of the residents. Because in the end, that's it. It's about the best interests of the residents and the health and their safety. That's what we're charged to do.
Right.
And so that has been, for my colleague who is working on this injunction, I've read several of the submissions, and that's really what they're around. It goes from being mindful that there are self-interests of family members, and that these are very dire situations that have an impact on the entire family system. However, in the end, it's not just the resident, but it's everyone the resident lives with and everyone the resident interacts with. So we have to trust that, like I said, good governance is helping us make those decisions. And then good leaders like Kelly are the ones who are, helping to enforce them and have conversations with these family members. I think that lawsuits around lawsuits and legal actions around this pandemic are a guarantee. At some juncture, something's going to happen on some level, and you've got going to have family members who really feel like they have rights and that their loved ones have rights, and they're advocating for their loved ones, which they might be. However, there's going to have to be a balance between the rights of family members and the rights of the residents, and then the rights of the group of the whole. So again, these are so many unanswered questions, but I think the way that you balance that risk is really stay very transparent in your communications, continue to keep family members and residents up to date on what's developing in the regulatory structure, why you're doing what you're doing, and then keep your, the lines of communication open. So to do some very proactive communications, crisis communications with family members in order to avoid grievances, claims down the road. That's how I would do it, is to just stay very transparent about what you're doing and why you're doing it. And of course, document that.
Great. Thanks, Rebecca. We got time for one more question. I'm going to toss this one to Kelly. How are you supporting staff who are balancing changes at home and work simultaneously?
Oh, that's that compassion, see. That absolutely is. I
So
have
the
2 small
compassion isn't
children.
just for your residents, it's for your
No, it's
employees.
for all of us and all of us coming together. You know, I have 2 small children at home, and thank goodness for my husband being able to work from home and manage school and all those pieces. But summer's coming, and I would share the emotional toll on our staff, the resilience in our staff, the ability to stay together and say, we are not just going to this isn't going to be over. This isn't a light switch. There's endurance, right? And so how do we be nimble? How do we create systems and then look at them again and say, gosh, we might need a buddy 2.0 system, you know, and to be able to always be listening to our staff, thanking them. Sometimes education can bring about a sense of security. And so when we can have a one-on-one, most of my education right now has been one-on-one. Our infection control nurse is doing a beautiful job talking to everybody and making sure that the competence and the infection control practices are right. So that brings some sense of security for our staff, but the compassion piece of, okay, you've got a baby at home. You know, let's talk through how you go home. What happens between you leaving this building and going home? And let's make sure we can make sure every piece of that is as safe as possible, that we are doing to keep you safe, keep your family safe, and keep our residents at Duncaster safe. You know, the one line that keeps going through my head, and it was a leading age conference a couple of years ago, one of the speakers, she said, you know, and I believe it because I've seen it for 25 years with my friends across this country and in Connecticut. We don't just care for one of our residents, we care about them. And this is a subtle piece that we too are grieving that families can't come. We too are grieving that how do we make it happen? How do we get the PPE to make these things happen? And that ability to partner with our state government and Department of Public Health helps us share our thoughts of how maybe that could come about safely. And they've been great. We've had great calls with phone calls. Ag Morelli, our state exec from Leading Age, is definitely taking all of our questions and our ideas and bringing those together. When the Department of Public Health has come to survey us at this time, it's a sharing of ideas and things. So that works very well. And each continuing care retirement community, each building, each neighborhood, each may have to do things a little bit differently just based on the design of their building, but that ability to do that exists within being compassionate, from big decisions to one-on-one conversations with you know, somebody who is, I don't know, somebody worked in our dining room who just had these personal concerns and fears and need to know who they can go to. Also, in our human resources has been outstanding to offer every support service that that we can give them for emotional help as well. And food, we've been eating very well. So.
Feed them. Yeah. Well, unfortunately, that's all the time we have. Kelly and Rebecca, thank you so much for joining us today. If you're joining us live, if we didn't get to your questions during the program, fear not. Both Kelly and Rebecca have graciously agreed to answer your questions after the fact, and we'll get their comments posted on our Facebook Live page as soon as possible. Also, please comment and tell us what other COVID-19 education you'd like to hear. What other programs would you like us to put together in the future? We'd love to know what's the burning topics on your mind are. And make sure you follow MedIQ on any of our social platforms such as Facebook, Twitter, LinkedIn, and Instagram. We have all kinds of great education, clinical risk management, and patient education in many formats, including more on COVID-19 and telemedicine, and more coming soon. Thanks again for joining us. Keep washing your hands and have a great day.
Thanks, Mark. Thanks, Kelly.
Thank you.
Thank you. Bye.